risk of having a stroke. There are several reasons that are listed here. It helps us to better educate patients about the risk of recurrent events. And this may increase their motivation, their excitement, to adhere to medications and lifestyle changes. It assists us in guiding physician or doctor decision-making in terms of selecting patients who need more intensive risk factor control, and we can identify which patients need more education. And this also is important to inform government and healthcare officials about global and regional issues, so that the people who run the government and the health ministries can target their resources and can elevate or promote disease prevention and treatment programs. Next slide, please. So I'm going to tell you about three major studies: InterStroke, ESSEN, and the REACH registry. InterStroke looked at 6,000 patients, of which 1,100 came from Southeast Asia, China, Malaysia, and the Philippines. They enrolled patients with a stroke within 72 hours of hospital presentation who had imaging evidence of a stroke. They looked at controls who were community-based and they were matched for gender, ethnicity, and age. They used a questionnaire to get information about their risk factors. In addition, they measured various cardiovascular risk factors such as blood pressure, waist-to-hip ratio. That's what they looked at. They looked at non-fasting blood samples, and random urine samples were obtained in these cases. The objective was to assess the association between stroke and certain major vascular risk factors within defined ethnic groups and geographic locations. Next slide. So this was what InterStroke found in terms of modifiable risk factors for stroke. And I think these are all common to you. Hopefully this just reinforces what you already know, that some of the most important risk factors were hypertension, smoking, obesity, bad diet, lack of exercise, diabetes. And all of this has been seen in study after study. And this really just confirmed that these risk factors were very prevalent, were very important in an Asian population. Next slide. Now, they compared large artery and lacunar infarcts in people in InterStroke who were from Malaysia and who were from Australia. So Malaysia and Australia, they compared the two for large vessel and small vessel, just to see what the risk factors were like in a mostly Asian population represented by Malaysia, and a mostly Caucasian population represented by Australia. And again, in some cases, things were the same, and in some they were not. So hypertension was essentially the same across the board. Large vessel, small vessel, Malaysia, or Caucasian, across the board. Diabetes was different. Certainly more diabetes in Malaysian folks than Australian folks. Prior vascular events, more of those in Malaysian folks than Australian folks. Smoking was high across the board, but a little bit higher in Malaysia than Australia. But again, it was pretty high across the board. Excess alcohol intake, this was higher in Australia than in Malaysia, maybe because of the Muslim population and the alcohol issues, yes? Congestive heart failure, very rare. What about high cholesterol? High cholesterol, much more prevalent in Malaysian population than Australian population. Much higher in Malaysia than Australia. Right? So we got to lose weight. We got to eat better. Eat better. Less McDonald's. Next slide, please. So that was InterStroke. Now let's move on to the ESSEN stroke registry. The ESSEN stroke risk score, which was derived from their population, actually was derived from the Capri study. 6,400 patients with ischemic stroke. And then they validated this in the ESPS2 study, which was a study of an antiplatelet therapy. And it was further validated in over 15,000 patients from REACH who had ischemic stroke or TIA. And these are the major elements of the ESSEN stroke risk score. If we go to the next slide. So This is how you get scored. You get 1 point or 2 points depending on your age. Then you get a point each for hypertension, diabetes, previous MI, other cardiovascular events, peripheral arterial disease, smoking, or if you had an additional TIA or ischemic stroke, in addition to whatever got you in to the baseline study, you got an extra point. So these are the ways that you calculate the Essence stroke risk score. Next slide. So if you look at the big picture of what does the Essence stroke risk score mean, you can see you're at low risk if you have 0 to 2 points. That means your risk of having a stroke is less than 4% a year. You're at high risk if you have between 3 and 6 points, meaning your risk of stroke is 4% per year or higher. And you're at very high risk if your score is 7, 8, or 9. So that's just how it breaks up. Low risk, high risk, and then super high risk. Next slide, please. So this is looking at the event rates for various Essence stroke risk scores. This is looking at the score, the number of patients. This is derived from the REACH study. And these are the event rates. And you can see it's a pretty good relationship. The event rates go from 2 to 3 to 4 to 5 to 6 to 8, 9, and then 11.5% when you get a score that's greater than 6. So that's pretty predictive, and it really lets you separate high-risk patients, here in the 6, 8, 9% range, from relatively low-risk patients in the 2 to 3% per year. These are event rates per year. Next slide. Now, what about the performance of the ESRS in a Chinese population? Well, this study, which just came out in Stroke last year, evaluated over 11,000 patients with an ischemic stroke or TIA who were followed for 12 months. Their risk was calculated using the Essence stroke risk score and this other thing called the SPI, the Stroke Prognostic Index. We'll just focus on Essence for the time being. And they were assessed for the occurrence of another stroke or the occurrence of a stroke MI or vascular death. And what they found overall in all of these patients was that the rate of a recurrent stroke was 16% in 1 year, which is quite high. And the rate for all vascular events was 18% in 1 year in this Chinese population. Now again, these are Chinese folks who had already had an ischemic stroke or TIA. So by nature of already having an event, they were in a higher risk group. And I'll show you in a minute what kind of effect that has. Next slide, please. So if we look for the 1 year follow-up for recurrent stroke, if the Essence stroke risk score was 0 to 2, the event rate was 12% with a stroke, although it went up to 16% if they had a TIA. But if the ESRS was 3 to 9, look at what that does to the rate. It's 20% for recurrent stroke in the recurrent stroke population, and 21% in the TIA population. So really a marked difference between a score of 2 or less compared to 3 or more in a Chinese population. Next slide, please. What about combined vascular events, stroke, MI, and vascular death? Well, it's the same story. If the ESRS was 0 to 2, 13% event rates in ischemic stroke. For the patients who came in with a TIA, it was even high at 18%. But look at what it does if the ESRS is 3 to 9, then the rates go to 23% and 24%. So again, a marked difference in risk going from an ESRS of 2 to 3 or more. And then this was one of the few studies to find this differentiation that the TIA patients had a little bit higher risk than the stroke patients. I'm not sure we fully understand that, but I can tell you, working with a REACH population, we found the same thing, that the TIA patients maybe had a little bit higher risk. Next slide. So, what about the Essence stroke risk score? This was results of a 1 year follow-up study published in Cerebrovascular Disease last year. They enrolled 730 patients with a recent stroke or TIA, followed for a little bit more than a year. Cumulative rate of a recurrent stroke, this is more of a European population, was about 10%. And again, they found that an ESRS greater than 2 was associated with an increased risk of all of these subsequent vascular events. So study after study, population after population, they all show that as your ESRS goes up, your risk of having a recurrent stroke or a recurrent vascular event goes up fairly dramatically. Next slide, please. So this is looking at the occurrence of ischemic stroke or stroke MI or vascular death. And what these curves are, these represent event-free survivals if the score is more than 2 versus less than 3. And you can see that there's a clear differentiation, but they're very consistent, be it an ischemic stroke event or having a stroke MI or vascular death, how the differences shape out. But again, the higher scores are always associated with worse outcomes. Next slide. Now, this group just published this in Sumi et al. In the International Journal of Stroke, trying to improve upon the ESRS and develop a modified score, a modified assessment, to see if they could better use the ESRS to predict events. And again, this was just published in the International Journal of Stroke a few months ago. So they added the following clinical features to the standard ESRS. Waist circumference greater than 90 centimeters, male gender, and then stroke subtype. And they looked at over 3,500 Japanese patients who had non-AFib strokes. And they evaluated this modified score for 2 endpoints: the rate of recurrent stroke, which we talked about before, and the occurrence of stroke MI, vascular death, and angina. And again, these were the modifications for obesity, gender, and stroke subtype. Next slide, please. So what they found is that with a modified score, this was very good at predicting the risk of recurrent events. You can see here, this was the predicted risk, and this is what they actually found in the study with the bar graph here. And it worked out well for both the stroke events as well as the vascular events. The predicted event rates and the observed event rates were fairly consistent. And you can see here very clearly, as the score goes up, the risk of having an event goes up. Score goes up, the predicted and observed risk of an event goes up. So we'll have to see, this is a brand new modification of the ESRS. We'll have to see how accurate this is found to be in other populations, in other prediction paradigms. But very interesting, brand new data. Next slide, please. Now, all of these studies, to be honest with you, have some important limitations. And the recurrent rates vary in these different studies because you're looking at different populations, differences in medication use, differences in follow-up, maybe some lack of sensitivity for all ranges of each scoring, and then you have patient dropouts, and it's not clear how those were accounted for. Each study excluded some stroke types. For example, many of the studies exclude cardioembolic strokes, but those people are at very high risk, so I don't know whether that's wise to exclude them. And then the different studies had different times to enrollment from their index event. In other words, they might have had the stroke, in some cases a few weeks ago, in some cases a few months or years ago, before they enrolled them. But we know that sometimes that risk is higher the sooner after an event you've been seen. So they might have missed some early recurrent events. Next slide, please. So now the next study to talk about is the REACH registry. This was an international study of over 68,000 patients from all over the world, over 5,500 hospitals and medical centers in 44 different countries. And they could be enrolled with symptomatic cerebral or cardiovascular disease or CVD risk factors. So you could get into REACH by having a lot of risk factors, which about 20 or 25% got in, or the majority got in because they have already had a symptomatic event. They were followed yearly to look at outcomes, and the treatments were determined by their primary physician. They were not mandated to have to be treated with a certain medication. It's whatever their primary care physician chose to treat them with. And that's one of the things I like about the REACH registry. It's sort of a real-world snapshot in terms of what happened in routine practice. Patients throughout the world with these diseases and how they got treated. So let's look at some of the baseline results. So you can see here geographic distribution of where these patients came from. And what I'm going to show you now is 3-year follow-up data. And there were 48,000 patients enrolled at 5,000 centers in 30 countries who were in this 3-year follow-up. And you can see, if you add China and Japan and the rest of Asia, you have about 17% of the REACH registry that was from Asia or Southeast Asia. Another 5% were from Australia. But a fairly diverse registry. So the aim is to report the 3-year medication use and outcomes in symptomatic patients enrolled in the registry, which is the 39,675 that we had data on. Other outcomes, we looked at MI, stroke, vascular death. We also looked at rehospitalization for vascular events. Because this is very important. If a patient ends up back in the hospital, it means that something bad happened to them. And that's a tremendous financial stress on patients and countries and governments. So we added that to the endpoint. We added rehospitalization to stroke, MI, and vascular death, if they were rehospitalized for a vascular event. Next slide, please. So these are the demographics. This is the baseline, just for the symptomatic patients, and the 3-year follow-up, just for the almost 40,000 symptomatic patients. And as might be expected, 2/3 were men. And these other risk factors were very prevalent: hypertension, diabetes, high cholesterol, obesity, smoking, heart failure, AFib, very high risk population. Next slide. This is the type of vascular disease that patients had at baseline in the REACH registry. This color here represents CAD only, and then this represents cerebrovascular disease only, and then this represents peripheral arterial disease. And then these smaller slices represent some combination. For example, the purple here, almost 4,000 patients, these had coronary artery disease and cerebrovascular disease. So you can see the vast majority of the patients in REACH had coronary disease, cerebrovascular disease, or some combination of the two. And I suspect this is very relevant to the population of patients that you see in your practice. Next slide, please. So what about medication use? And in REACH, we just collected data on broad categories of medication, not specific medicines that they might have used. But you can see here, again, the vast majority of patients were using antihypertensive therapy, antithrombotic therapy, of which aspirin alone was very common, aspirin and other antiplatelet agents in about 12 to 14%. Lipid-lowering therapy, 75, 76%, of which most were statins. And then many of the diabetic patients were taking medications. So the point I want to emphasize is that in the REACH population, they had a lot of vascular risk factors, and they were treated for a lot of vascular risk factors, or at least they were taking medications that should have treated their vascular risk factors. So this was a fairly well-defined, well-treated population. But look at what happened. Next slide. Okay, so these are just the symptomatic patients. The yellow is 1-year event rates. The orange is 3-year event rates. Over here is stroke, MI, vascular death. Over here is stroke, MI, vascular death, and rehospitalization. Look at the 3-year event rates. 12%. And 28%. This is huge, ladies and gentlemen. This is huge. This means that over a quarter of these patients, who, as I just showed you, were fairly aggressively treated, ended up with a stroke, MI, vascular death, or back in the hospital in just 3 years. In just 3 years. Next slide, please. This is a breakdown looking at the symptomatic patients. Again, showing you the breakdown between stroke, MI, and vascular death, which at 1 year was 4.7%. And then rehospitalization by itself was 11%. So almost 3 times as many ended up in the hospital for some other vascular issue. And then at 3 years, where we had almost 40,000 patients, again, 28% stroke, MI, vascular death, rehospitalization, of which rehospitalization for just another event was 21%. Which is huge, represents a huge number. Next slide, please. Now in this slide, we're just looking at the patients in REACH who are symptomatic with a stroke or a TIA. So this is just the stroke or TIA folks looking at 1 year and 3-year outcomes, just for the stroke and TIA folks. And look at what they are here. 3-year outcomes for recurrent stroke, over 8%. Stroke MI vascular death, over 15%. Stroke MI vascular death or rehospitalization, over 28%. These are huge numbers of patients that went on to have a bad outcome. Next slide. Now in this slide, we're looking at patients who had events in a single vascular bed, like just the brain, or just the heart, or just the leg, versus patients with symptomatic disease in more than one vascular bed, like the brain and the heart, or the heart and the leg. That's what we meant by polyvascular disease. And now we're looking at 3-year outcomes. Look at stroke MI vascular death, monovascular disease about 10%, polyvascular disease almost 18%. What about if we look at the endpoint of stroke MI vascular death rehospitalization? With single bed disease, it's 25.5%. With polyvascular disease, it's more than 40%. 40%. A little bit less than half of these patients had another event. That's just enormous. That's a very bad outcome. Very bad outcome. Next slide, please. There were also regional differences. Okay? Eastern Europe did the worst. Okay? Eastern Europe did the worst. Vascular death, 9% versus 5.5% of the whole population. Stroke MI vascular death, 18% versus 12%. The triple endpoint, almost 40% in Eastern Europe. By comparison, Japan did really well. They had very low event rates, much lower than the average. Japan. And what about Asia? If you look at all Asian countries, in general, the Asian countries were about average in overall outcomes. Vascular death, 6% versus 5%. Stroke MI vascular death, 13 versus 12%, about the same. You had rehospitalization, a little bit better, 23 versus 28%. So again, the Asian population wasn't really bad, and they weren't really good. They were sort of average. Which is okay, but still, if you look at stroke MI vascular death rehospitalization, 23%, that's still a high number. That means almost a quarter of the patients from Asia went on to have one of these outcomes. Next slide. Now there are some limitations. Many of the outcome events were not adjudicated. However, the stroke endpoint was one of the few that had to be adjudicated and had to have supportive documentation. So if someone was dizzy, they couldn't be called a stroke unless they had a brain scan or some other test to really show that it was a real stroke. Adherence to medication use was not routinely verified. And that is an important point. It's one thing for the patients to come in and say, yeah, I'm taking my aspirin, I'm taking my Plavix, I'm taking my statin agent. But who knows if they really took it? If your patients are like my patients, half the things they say that they're doing and taking aren't true. So I think that may be one explanation for why it looks like they were well treated, but they really weren't that well treated. The other aspect is that the achievement of target risk factor reduction was not determined. In other words, they may have had high blood pressure, they may have had hypertension, and they may have been taking blood pressure medications, but their blood pressure was still high. So just saying you're taking the medicine is not the same as saying you're taking the medicine and your blood pressure is under control. So that's an important fact. And then since the REACH registry, as all registries do, had specific enrollment criteria, we cannot rule out that there might have been some selection bias in terms of the people that got into the study. Either good or bad, but some bias. Next slide, please. So the summary of key results. Symptomatic patients in the REACH registry had very high event rates, despite the widespread use of various medications. Patients with polyvascular disease had much worse overall outcomes. Rehospitalization was the most common outcome event. It was a very bad outcome event. There were significant geographic differences in the outcomes, and the high vascular event rates reported in REACH point to the need for improvements in the prevention of vascular disease. Next slide, please. Now, I want to touch on a new topic, and that is the diagnosis of TIA and stroke. And this is based on the recognition that TIAs that last more than an hour are often associated with ischemia or infarcted brain on the MRI scan. And in fact, up to 50% of patients with a clinical diagnosis of a TIA will actually have evidence of a new diffusion-weighted lesion abnormality on MRI consistent with a new stroke. And now the guidelines, at least the US guidelines, have changed the diagnosis of TIA to stroke based on the MRI results. Next slide. And it's based on these data, which was a compilation of 10 different studies that enrolled over 800 patients, and they looked at the duration of symptoms and the percent of patients that had a new diffusion-weighted abnormality on their scan. And you can see that even at 1 hour, about a third of patients had a new diffusion abnormality on their scan. But you can see here, as the duration of their symptoms went up from a few hours to 4 to 6 to 8 to 12 hours, the percent of patients that had a new lesion on their scan went up to almost 50%, meaning that up to 50% of patients who look like they're just having a TIA may in fact have had a stroke. Next slide, please. And this is a MRI scan with diffusion-weighted imaging in someone with transient TIA symptoms that went away after a few minutes or a few hours. And you can see all of these white dots represent new, small ischemic strokes. Next slide. So based on this, the American Heart Association has redefined a TIA and stroke with the following definition. A TIA is a transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. So based on the new definition of TIA, an ischemic stroke is defined as infarction of central nervous system tissue without regard to the severity of symptoms or how long the symptoms lasted. Now, this is obviously imaging dependent, and without advanced imaging, you're going to have to rely on your standard clinical definitions. Next slide. So, if you look at the TIA stroke continuum, this is just my interpretation of it, but try to make sense. A TIA, you have transient ischemia, no infarcted tissue, symptoms totally resolve in a few minutes, and the MRI is normal. A minor stroke, you have a small amount of infarcted tissue, the MRI is abnormal, and the symptoms perhaps last longer. And then a real honest-to-goodness stroke, you have a large amount of infarcted tissue, your symptoms persist, and the MRI is clearly abnormal. Next slide, please. Now, there are some limitations. We know that MRI is much more sensitive than a head CT to detect the presence of ischemic tissue. But suppose you can't do an MRI. Maybe it's not available, maybe the patient has a pacemaker. What you can do is maybe repeat the head CT scan in 48 hours. And if there is a new stroke there, then it's a stroke. If it's normal and the patient's symptoms have gone away, then I guess you need to really call them a TIA. Now, the new definition will make comparison studies of stroke and TIA in the future very different because we're using a new definition, at least in the US. And this may increase the number of strokes because we know that MRI is very sensitive for picking up strokes. So in terms of getting more resources from the government, we have better imaging that say more patients having strokes, they'll see stroke going up. Maybe they'll make more resources available. Maybe you'll get more money for the hard work you do. Maybe not. Okay, next slide. So very briefly, I'm almost ready to close. This is just a general approach to secondary stroke prevention, controlling risk factors, antiplatelet therapy, anticoagulants, now mainly used for cardioembolic strokes, statin therapy, and then surgery or endovascular therapy such as carotid endarterectomy or carotid stenting. And this is just a broad approach. I'm not going to talk about each one of these because time is almost up, and I know you have I'll let him go to work for the next slide. And when we talk about antiplatelet agents, there are four main antiplatelet agents used in the United States. Aspirin, which is safe, better than placebo, low cost, limited efficacy. Cyclopidine, which we don't use much anymore because of side effects. Clopidogrel, which is Plavix, which we use a lot. It's much better tolerated than is cyclopidine. It's more efficacious than aspirin. Agranox, which I don't think you have available here, so I won't talk about that. And then Silastazol, do you have that available here? Yes. Silastazol is more effective than aspirin alone, but it's limited by GI side effects and headaches. Next slide. So let me conclude by saying that the Essence Stroke Risk Score is a valid method to determine future stroke and vascular risk. The REACH registry has shown that patients with symptomatic disease are at very high risk of subsequent vascular events. Patients with disease in more than one vascular bed are at very high risk of future events. Many patients who you think clinically have had a TIA have really had a new stroke based on the new MRI imaging criteria. And I think at the end of the day, we need aggressive therapy and risk factor control in many cases to reduce the risk of subsequent events. I want to thank you all and thank the organizers for the gracious invitation. It's been my privilege and honor to talk to you. And if there's time, I'm happy to answer any questions. Thank you very much.